Good evening, everybody, and welcome to the Pancreatic Cancer Early Detection and Screening and maybe at some point interception webinar. I'd like to thank Letitia Taniwaki, who has been very instrumental in making this webinar happen, and Danielle Sipes, who has made the flyers. It's now with great pleasure for me to introduce my two panelists, Dr. Zhen Wang and Dr. Sun-Chuan Dai. Dr. Wang is a world-class expert in MRIs and pancreatic cancer MRI, and I think it's the luxury of UCSF to actually have an expert that is really focusing on imaging of the pancreas. Dr. Dai is doing the more invasive procedure. He looks at endoscopic ultrasounds and he's going to tell you all about it. I think as you will hear during their presentation, a little bit like, what does pancreatic cancer screening mean? What are options we can do? Who should have it? And I think part of what we created in our BRCA clinic is really the inability for a patient to see us and get very personalized screening recommendations. Since we started this in 2015, the recommendations for pancreatic cancer screening have very drastically changed, and I think they will continue to change. And I think we'll come back, and when we open our webinar for Q&A, we'll go a little bit more in the details. Who should be screened and should screening be applicable to you? I will now hand it over to Dr. Wang. I also like for you, Dr. Wang, to tell us a little bit more about who you are, what you do, why you focus on pancreatic cancer imaging and screening. You are on mute.
Share. Thank you, Dr. Munster. Let me now share my screen. Can you all see my slides? Hopefully.
Yeah.
So great. Well, thank you, Dr. Munster, for the introduction, and good evening, everyone. Thank you for joining this webinar. My name is Zhen Wang. I'm a professor of radiology here at UCSF, and as Dr. Munster mentioned, that pancreatic cancer imaging is one of my interests, and I actually had a very close family member who lost the battle to pancreatic cancer, so it's very personal to me as well. And I've done some work in both pancreatic cancer screening as well as in just imaging pancreatic cancer in general, especially in the setting of early response assessment. And it's a very challenging area for imaging because of the nature of pancreatic cancer. And certainly in terms of early detection, we still have ways to go. But we are definitely working hard on trying to get better at detecting pancreatic cancer early. So I'm sure we will talk a little bit more, especially during the Q&A session. There is, here at UCSF, we do have a screening program for pancreatic cancer in elevated patients with elevated risk of pancreatic cancer. And I generally think about these in three groups. Now, most of the more established pancreatic cancer screening program is really for high-risk individuals. And these are patients with familial pancreatic cancer and or some type of pathogenic germline variants. We also do a lot of imaging in patients with cystic neoplasm, and these are pancreatic cystic neoplasm, especially for the mucinous type, which does have a higher malignant potential. And more recently, especially in the imaging realm, there's a lot of interest in how to better screen patients for pancreatic cancer in these patients who are over 50 with new onset diabetes, because the thought that this is a group that has increased risk of pancreatic cancer. And I'm sure many of you know that pancreatic cancer survival is very heavily dependent on the stage of the disease. So at stage 1 at diagnosis, the 5-year survival is about 45%. And if it's diagnosed at later stage, it is dramatically lower. So in terms of surveillance methods, especially for the high-risk individuals that I mentioned, really, we're thinking about imaging, the non-invasive imaging study. Here, we're talking about MRI and MRCP. And then Dr. Dai will talk after me about endoscopic ultrasound screening. And I think of these really as complementary methods. And the literature has shown that MRI is quite good at picking up these tiny cystic lesions on imaging, and many of those are of no consequences. However, there are some that have malignant potential. Endoscopic ultrasound does have better accuracy in picking up small solid tumors. We usually think of these as complementary. So when we talk about MRI, MRCP, I know the terminology could be a little bit confusing. At UCSF, we do the screening exam with MRI with contrast, that these are intravenous gadolinium-based contrast material. And MRCP, what that really is just a specialized set of images that allows us to better look at the pancreatic duct. And again, MRI, MRCP, they're non-invasive. They are radiation-free. We here do our exam almost always with intravenous contrast because we think that increases sensitivity at detecting small tumors. And what we're really looking for are small tumors. And sometimes these pancreatic tumors could be very, very subtle. They look on imaging, they look the same color as the normal pancreatic parenchyma. And so the other thing that we are looking for are really secondary signs of tumors. So is this obstructing small ducts or the pancreatic duct? Even if we do not see a visually visible mass, if we see isolated pancreatic duct obstruction, we are very, very worried in those situations. So just an image to show that this is an image of the abdomen. I kind of cropped it to draw your attention to the pancreas. This is an image done following intravenous contrast administration. So these are contrast dye that's injected into the vein and it helps highlight the organs. So again, this is the abdomen. We're looking at a cross-sectional imaging. So this is the patient's left. You see the liver, and these in the back are the kidneys, and the pancreas lives in the middle of the abdomen. And this is what normal pancreas looks like, the what we call enhancement characteristic or enhancement pattern. This is what normal pancreas look like. And then this is what we are referring to as the MRCP. Again, this is kind of a cropped down picture to show the pancreas here. And these set of specialized image helps us look at the pancreatic duct better. So here is the pancreatic duct, and this patient happened to have a pancreatic cyst that we have been following. So that's MRI, MRCP. We certainly could also do screening with CT. It is an alternative to MRI, and it has been done to screen for pancreatic cancer in high-risk patients at some centers. Here we do MRI. For CT, it is definitely a faster imaging modality. These images acquired within the whole study might just be 5-10 minutes, and then the actual acquisition of the imaging usually is under a minute per set of images. Again, we would do these with intravenous contrast. We're looking for the same thing. We're looking at masses in the pancreas and looking for secondary sign of tumors. So this is a reformatted image. It's a coronal image. So you really looking on as if you're looking at the person frontal on. So you can see the bottom of the heart, here's the liver, and here is the pancreas. And what you can see here, this patient actually has a small pancreatic cancer at the pancreatic head, which is actually very hard to see, but it is obstructing the duct. So this dark line is the pancreatic duct, and this duct is dilated, it's obstructed. And that draws our attention and makes us worry that there is an underlying tumor. And indeed, this patient was diagnosed with pancreatic cancer. So some of the findings that have been described as early findings on imaging, even up to about 4+ some years before the actual diagnosis, one can see focal pancreatic parenchymal atrophy. What it means is that parts of the pancreas, it shrinks and it abnormally shrinks. We can see what we call fibrosis or faint hyperenhancement. That's the color of the pancreas. Could be a little bit different in the area of tumor. And we can see these potentially about 3 years before diagnosis. And then when we see the pancreatic duct obstruction, that is about a year before diagnosis. Unfortunately, these findings are quite non-specific. So they are not specific to early pancreatic cancer. And many times the pancreas actually looks normal on the pre-diagnostic imaging. So clearly we still have more work to do on the imaging side to get better, more sensitive and specific imaging to detect pancreatic cancer early. So again, this is another case of pancreatic cancer in early imaging finding. This is what I was referring to as the MRCP sequence. You can see this white line, that's the pancreatic duct. And again, this looks more dilated than it should be. And that there is a tumor, which is very hard to see here in the pancreas, head of the pancreas. And here's a separate patient. This is images following contrast administration. And there's a very subtle tumor in the pancreatic head that the color of this looks slightly different. So these are the things that we're trying to look for when we screen for pancreatic cancer, or really for any of our imaging studies that we do. Here's another case. In this case, this is a CT in this patient. This dark line is the duct, and this is just very subtly obstructed in a patient who was subsequently found to have a small pancreatic tumor. As I mentioned, that we also do surveillance imaging in patients with pancreatic cyst, and that there are specific things that we look at in terms of the cyst and how likely that these cystic lesions could be malignant. And so here it just lists some of the features that we look at: the size, whether a lesion is entirely just a fluid imaging, or is there soft tissue associated with the cyst. So these are some of the imaging findings that we look for. So how good are we in terms of doing imaging and detecting cancer in high-risk individuals? So these are a fairly large number of studies that are published in the literature, and these studies mostly looked at patients at high risk for pancreatic cancer, hereditary syndromes, germline variant. And what we know is that imaging screening, it does pick up cancer. So for these, it picks up, anywhere about 1 to close to 9% of cancer of the patients that are screened. And this lists the percentage of the patients from that screening program, how many of these are resectable. And you can see that it is quite good, somewhere between 60 to 100% of these patients end up being resectable, where if for the general population, for patients who are diagnosed with pancreatic cancer, the percentage of resectable cancer is much, much lower. So we're clearly picking up cancers that are more likely to be resected. However, we look at the percentage of stage 1 cancer, it's quite variable. Some are, this series is picking up stage 1 cancer at a close to 80%, where another series is picking up, less than 10%. This is a relatively smaller study. So what is that? What is it telling us is that despite screening, many cancer are still diagnosed, unfortunately, at a more advanced stage than we like. And again, many pancreatic cancers show no pancreatic abnormality in the previous imaging within the 12-month preceding cancer diagnosis. So it is very, very challenging cancer to detect early, and there's more work to be done. There is work looking at innovative imaging or combined imaging and clinical data to detect cancer during the subclinical phases. And a lot of work is ongoing both at UCSF and elsewhere using artificial intelligence algorithm to see if we can pick up early cancers, especially in high-risk individuals. So I want to stop here, and I know we have a time set aside to do Q&A, but thank you. Let me stop here.
Thank you so much, Dr. Wang, and I think you've given us a lot of food for thoughts, and I've taken notes for more questions in the Q&A. Dr. Dai, would you please tell us a little bit who you are and why you do what you do and what you do?
Absolutely. Let me share my slides first. Mm-hmm. All right, can you guys is my presentation on right now?
Yep.
Okay. All right. So my name is Sun-Chuan Dai, and I'm one of the faculty in the Division of Gastroenterology. I'm an associate professor of medicine, and I also serve as the medical director of endoscopy for UCSF Health. And a lot of my clinical practice and my academic work involves looking at pancreatic cysts. And I do have an interest in pancreatic cancer screening. The reason that I do these things is, my field is very, very procedural based, but one of the things that we often encounter that where there's still a lot of room to grow is how we manage, how we diagnose, how we treat a lot of these, not just pancreatic, but biliary cancers. So again, my field is somewhat of a more procedure-oriented field, and this is often what we see every day. And it's often very difficult to see our patients fighting these battles. So that's what motivates me in what I do. Now, I just, oftentimes when I meet patients who are getting screening for pancreatic cancer, there's a certain level of there's often I will say a gap of understanding exactly what an endoscopic ultrasound is. So I'll just start off. Sorry, I do have some disclosures. I do consulting work for Boston Scientific. But most of you are probably familiar with a gastroenterologist in the sense that you have gotten either an upper endoscopy or a colonoscopy. Colonoscopies, the implementation of screening colonoscopies have been shown to decrease the incidences and death rates of colorectal cancer. And upper endoscopies are typically done when individuals have either some sort of upper GI discomfort, or if there's any sort of pre-malignant conditions of the stomach. So this is a standard upper endoscope. The camera looks forward, and if you look at the picture on the bottom right, this is an erosion or like a baby ulcer in the stomach. So this is what you get with endoscopy. You get live images, they're in color. These are endoscopic views. So an endoscopic ultrasound is different in that this black piece here, this is the ultrasound probe. So you run the scope down, you can get camera views of the GI tract just like the image before, but the camera actually looks out the side, and that's in order to accommodate this bulky ultrasound probe. And this is a biopsy needle. So this doesn't come with the scope. This is a separate device, but there is a biopsy channel. So if you see something that looks suspicious, this is how you would grab a specimen to try to figure out what it is. And because of the nature of these procedures, most gastroenterologists do not do endoscopic ultrasounds. Currently, there is essentially a requirement that once you finish your gastroenterology training, if you want to do these procedures, you have to do another year of training. And that's because you're looking at ultrasound images. That interpretation is very different from looking at live endoscopy images. And if you think about a camera that only looks out the side, it's sort of like driving a car, but you can't look out your windshield and you can only use your driver's side window as reference. Typically, when it comes to looking at the pancreas, the endoscopic ultrasound is advanced to the first part of your small intestine. This is called your duodenum. And this tan glandular organ, this is your pancreas right here. And your head and the uncinate of the pancreas are sort of wrapped by the duodenum. And this graphic doesn't demonstrate it, but the body and the tail of the pancreas extend towards the upper right corner. They are actually typically sits behind the stomach, which is why you're not really seeing the rest of the pancreas here. But typically, we advance this probe down to the second portion of the duodenum. And if you think about the visualization coming from the probe, so we are scanning along the entire uncinate and head of the pancreas when we're in the small intestine. As we pull the scope back to the stomach, then we start getting nice views of the rest of the body and the tail of the pancreas. This is typically done when the patient is usually in the left, laying on their left side, what we call the left lateral position. And again, the scope gets advanced down the mouth, esophagus, and to the stomach and the duodenum, and that's where we are getting views of the pancreas. Now, usually while we're there, we are able to grab endoscopic views of the stomach. So sometimes we have patients asking, I'm afraid I might have an ulcer. Can you take a look at the same time? Yes, we're able to do that. And we're also able to look at a variety of other organs. So we can see parts, but not the entire liver. We can see any lymph nodes that are around here, outside the walls of the stomach and the rest of the GI tract. And another important part of endoscopic ultrasound, which really isn't necessarily applicable to patients who are getting screening, is that we do visualize the bile duct and we can look at the gallbladder here. So we can actually see a lot of different organs. There's actually some other organs that aren't even within the boundaries of the GI tract that we can see. We often see both the right and the left kidney, for example. We can even, though we're not formally trained to do this, but if we have the scope in the esophagus, we can actually do an echocardiogram and see the heart. So this is now on endoscopic ultrasound again. So in contrast to endoscopic images, ultrasound images they basically come in black, white, gray, and I'll point out a few things here. So this is a gentleman that I just did a screening last week, and his pancreas, I'm looking at the body of his pancreas right here. So it's often described as a salt and pepper appearance, but what my mouse is circling around, this is his pancreas. On ultrasound, fluid structures will appear black. So anything that's black is either going to be a blood vessel or it is the main duct of the pancreas. And in this instance, this is the pancreas here. This is the main pancreatic duct. It's nice and thin. So basically, this is what happens as I'm scrolling through. I'm just looking back and forth. I'm trying my best to trace the pancreatic duct here, and which is sitting right here. And sometimes to make sure I'm not looking at a vessel, we turn Doppler on. So this large structure is a large vein. I think I missed it earlier, but there's actually a cyst right here as well. Let's see if I can bring that up. Right here, that's a cyst that's smaller than a centimeter, doesn't have any high-risk features. But this is what we're doing during an endoscopic ultrasound. So we run the scope down, and then we start scanning on each section of the pancreas back and forth. Usually the pancreatic duct is a nice reference point to know that we're still on the pancreas. And again, we actually see some other organs along the way just by sitting, even in this video. Where was it? You can see the patient's left kidney right here. And there was an adrenal gland that I saw earlier too. And usually from this position, you also see the aorta. So again, the endoscopic ultrasound is a wonderful tool in that we do see a lot of things, but especially in this instance, we get really great views of the pancreas. And typically, if something suspicious is seen in the pancreas, the best way to grab a tissue in our current sort of era of medicine, it would be an endoscopic ultrasound. In terms of logistics of how the procedure is, usually, at least for screening patients, this is an outpatient procedure. Patients are sedated with an anesthesia provider. Sometimes you may have noticed that people who get colonoscopies can get just some IV medications administered by a gastroenterologist, by myself, but our hospital requires that we do have a special anesthesia provider present. There's no bowel prep that's required. You're not, for a colonoscopy, that's where you have to drink that large, nasty fluid and clean out your bowels. But for endoscopic ultrasound and any sort of upper study, you just have to not eat anything after midnight on the evening before your procedure. And we typically do these procedures at our Parnassus and our Mission Bay campus. So what's the difference between an MRI and an endoscopic ultrasound? I think Dr. Wang said it really perfectly that these are complementary studies. So in terms of what an endoscopic ultrasound offers is that we are able to biopsy, because as we're scanning, if we see something that's abnormal that warrants a biopsy, we are able to do it right there. We can sometimes get more precise measurements, and that's just because we're looking at things a little bit more closely, and we also have calipers just like the radiologist does. We think that smaller cancers can be picked up, and this has been mentioned in the literature. I would say this, I've found cancers that are a centimeter in size that perhaps may not have been caught on imaging before. And we're also able to do any sort of concurrent endoscopic procedure. So I have had patients who say, listen, I'm due for my colonoscopy this year, and my regular gastroenterologist was going to do it, but I don't want to get sedated twice, or I don't want to take 2 days off of work. So yes, we are able to do an endoscopic ultrasound or any other upper endoscopic procedure and then do a colonoscopy at the same day. Now, the downsides is that this is obviously much more invasive than getting an MRI. You have to take essentially at least half a day, if not a full day off, because you will be getting sedation. And of course, there's always risk with procedures. I don't consider endoscopic ultrasound to be a high-risk procedure within the realm of the work I do. But we do typically, when consenting patients, we do say the risks are bleeding, infection, and perforation. And usually this is very low. This is less than 1 out of 2,000. Again, I think I agree that this is very much a complementary procedure with MRI. I do think I think there are some very specific instances where I like an MRCP better to look at the pancreas. There's also regions of the pancreas where it's somewhat easier to miss things, for example. So sometimes pancreatic tail lesions can get missed, and an MRI would otherwise be able to catch that perfectly. So again, I typically do not advocate one modality over the other. When patients are interested in screening, I do recommend for both. With that said, I have had some patients who are very, very claustrophobic with MRIs, and for that reason, they get annual endoscopic ultrasounds. In terms of which patients we're screening and who we should be screening, our protocol at UCSF for BRCA patients pretty much follows what the CAPS consortium. This is the I'm drawing a blank on the abbreviation now, but cancer of the pancreas. This is a pancreatic cancer screening in international symposium. So typically we do for BRCA2 patients who have at least one affected first-degree relative or two relatives who are not first-degree. We do offer screening. We essentially do the same thing for BRCA1 patients. So that's anyone who has one affected first-degree relative or multiple relatives, multiple second-degree relatives with pancreatic cancer. There aren't any studies looking exactly at how great endoscopic ultrasound is for pancreatic cancer screening. All the studies look at screening in general, which would include MRI. And this is actually, this article is actually the second one that was in Dr. Wang's slide. But basically, this was published in 2022, and there's several sites that participate in the CAPS consortium. So they looked at about just shy of 1,500 patients who were screened at 8 locations from 2014 to 2021. In this group, they actually detected 10 cancers, but they left one patient out because that patient had sort of disappeared from screening and reappeared several years later with stage 4 cancer. But they picked up 9 cancers. 7 out of those 9 were stage 1, and they were all surgically resectable. And they're at a median post-diagnosis time of 2.8 years. 7 out of those patients were alive. The study is a little bit, admittedly, a little bit confusing, but they also talk about all of the CAP sites, and they did say that they picked up 26 patients with either cancer or high-grade dysplasia, and I think Dr. Wang mentioned this, but the survival rate after 5 years was in the area of about 73%. So I often tell patients, this is sort of the best data we have. It's not, I don't think it is a lot of patients. It's not as, when people talk about colon cancer screening, they're able to show a chart that by the decade since the implementation of screening colonoscopies, we've decreased the rates of colorectal cancer. So the data here is not as robust, but also because pancreatic cancer screening is sort of it's a practice that's been younger and hasn't been as well established as screening colonoscopies. I do want to point out that the ASG, this is the American Society of Gastrointestinal Endoscopy, they came out with their guidelines, and they're actually recommending anyone with a BRCA mutation, even without a family history, to get screening. However, this is what is described as very conditional with very low quality evidence. So this is often not practiced, and we usually do not follow this recommendation here at UCSF. But yes, this sort of information is out there. So in terms of future advancements within endoscopy for the purpose of pancreatic cancer, I think certain areas, I think endoscopic ultrasound, the tool itself, is already very good. I don't think there can be much more advances in terms of imaging when we're doing our procedures. But the area where there's a lot of improvement is detection of high-grade dysplasia and biomarkers for cysts. So now, not all cancers grow from pancreatic cysts, and actually the majority of pancreatic cysts do not eventually turn into cancer. But oftentimes when we stick a needle into a cyst to sample fluid, the sensitivity in terms of determining even a diagnosis of what the cyst is, forget about even picking up high-grade dysplasia, is less than 50%. So a lot of work is being done to see when we sample pancreatic cyst fluid, how can we be better at finding dysplasia, or are there any other biomarkers we should be testing for? So that's really the sort of major area for improvement within the bounds of endoscopic ultrasound. But again, that doesn't necessarily apply to high-risk patients who are getting pancreatic cancer screening. Like I said, not everyone will have pancreatic cysts. Otherwise, I really think the future of this area is moving towards less invasive screening, which sort of puts endoscopic ultrasound as, sort of, I suspect that, in a few decades, the screening ultrasound may not be done as frequently as we do it now. Otherwise, this is the rest of our team. So within the GI division, there's 4 individuals, including myself, who are interventional endoscopists who do endoscopic ultrasound. Mike Larson is our director of our interventional group. Patrick Avila and Abdul Kawanda are all trained here and have been in practice for close to almost 5 years now. So collectively as a group, I think we do about 1,500 endoscopic ultrasounds. Not all of them are screening. Some of them are because, someone showed up with symptoms and we see a lesion, and there's many other reasons why we do endoscopic ultrasounds. But I do think it's important that these screening procedures do get done at a center where you do have individuals who have a lot of experience with this. So I think I can turn this over if there's any other, and we can answer questions later.
Thank you so much for this. Before we go to the Q&A, I also like to talk a little bit of our pancreatic cancer screening protocol that we actually have. So I can find this. So we started a pancreatic cancer screening protocol for our patients, and there's a pilot study where we hope to enroll 100 or 200 patients for pancreatic cancer screening. These are the mutations, is either BRCA1, 2, ATM, or PALB2, and patients may or may not have a strong family history of any of these cancers. And I'll in the Q&A will talk a little bit more about the relevance of family history in families who only have one child nowadays. This is essentially looking at exactly what Dr. Wang and Dr. Dai just said, MRIs or endoscopic ultrasounds, but it allows us to actually follow those patients in a controlled fashion over years. We also try to collect blood and saliva tests to see whether we at some point find any biomarkers that may help us with having complementary tests in addition to the imaging studies. Inclusion is pretty straightforward. People have to be more than 50 years of age, have to have a documented mutation in BRCA1 to ATM or check. There are 2 groups. One group is looking at with the family history and the other one without the family history. Patients are only excluded if they had prior or active pancreatic cancer or if you're pregnant. This is the schema, and I think I'm gonna leave it at that and like to go back. So if you consider getting screening, please consider participating in this study so we can actually formally start following, like what are we seeing or what are we seeing in screening, and so go from there. So great presentations. I learned a lot. So if before I go into the question, there's a lot of really good questions. Like Dr. Wang, a lot of questions we have is like for the doctors or the patients, like what should the doctor order? What is the test to be ordered for the MRI? Is it abdominal MRI with the MRCP protocol? So and we put this in our things because I think it's causes a lot of confusion among our doctors and providers ordering this.
Yeah, that's a great question. I would say that the individual places name their MRI protocol differently. At UCSF, we do our pancreatic cancer screening with a protocol what we call as MRI, abdominal MRI with MRCP. And the MRCP is nothing special other than that there is some additional imaging, high resolution imaging taken of the pancreatic duct. Now, other places may call their protocol a little bit differently, where they may just call it abdominal MRI, where they already include that high resolution MRCP that takes a closer look at the pancreatic duct. I would say, I think there was a question in the chat Q&A that I answered. Even a good quality MRI abdomen with contrast should be sufficient, even if you do not have these high resolution imaging to look at the pancreatic duct, because all abdominal MRI, all good quality abdominal MRI will look at the duct. It may not be as high resolution as the MRCP, but it should pick up the ductal abnormality adequately. I hope that answered the question.
Yeah. So what happens if you find something but you don't quite know what it is? What are you going to do then? You ask Dr. Dai to have a look?
Yeah, I would say that if we see findings such as obstructed or such as what we call isolated pancreatic duct dilatation. So what it means is that sometimes people have dilated duct throughout the pancreas, and it could be due to various reasons that are not related to cancer. But if we see what we call kind of isolated or segmental ductal dilatation, that's when we are very suspicious of a tumor, even if we cannot actually see the tumor. And these, sometimes we recommend another imaging, such as a FDG PET, that is a imaging modality that provides metabolic information to see if there's anything in the pancreas that takes up the PET tracer. Sometimes patients might just go straight to endoscopy.
Okay. What's the likelihood for both of you to find something that ultimately is not pancreatic cancer? I mean, we always fear about the false positives, right? That leaves you very anxious and worried and ultimately turns out to be nothing. How often do you think you see this in either of your procedures? Sun? Go ahead. Sorry, Jane. You could go.
Oh, no, I was going to say, Dr. Dai, maybe you want to go first.
Sorry, I was just typing out a question. Did you say how often do you see false positives?
Yeah.
So you mean like if you see if you find something that looks suspicious on MRI and then you proceed with an endoscopic ultrasound, is that what you mean by you're describing as a false positive that's found on imaging first, right? So I would say that it can happen, but it doesn't. But I can't give you exact numbers, but I would say that rate is low. It also depends on where it depends on what image study you got and also where you had it. So usually when the times when I've had to do an endoscopic ultrasound because there was a positive finding on an imaging study, it's usually in the context of someone getting either an abdominal ultrasound, which really isn't a great study to look at the pancreas, or getting a CT. Sometimes that's done without contrast. Or other times it's getting an MRI at another center where their slices are not as thin, so the images just aren't as accurate. Those are those are usually the instances. So I just had a patient recently who was fortunate because she had a pancreatic tail mass that had been seen on an outside MRI a year ago. When I did the endoscopic ultrasound, I couldn't find it for the life of me. So I ended up having her get another MRI here at UCSF, and of course it was negative. So it does happen. False positives from a biopsy are usually quite unusual and low. Usually, if you see a mass in the pancreas and you stick a needle in it, most likely you will be able to get the diagnosis correctly. But it's very unusual where you see a mass and in fact there wasn't anything there at all.
Thank you. So I think our screening recommendations, as I said to beginning, have very rapidly evolved. I think over the last 10 years, we've gone from virtually no screening to pretty broadly screening people. And I think a big part of is still centered around the family history. Clearly, if you have a first-degree family member with a pancreatic cancer and you have a BRCA2 mutation, your risk is probably higher. The challenge is if you don't have a family member, you don't know your family, and many of our families are just not totally aware of what their relative's disease was, what they died of. Often patients really don't know that their relative had pancreatic cancer. It could be from somewhere. So I think we are not quite as strict in what it means to have a family history. I think if we are a little bit more liberal, and I think that's why we created our study, just to have a home for patients who want to be screened. They should be screened to enter a screening protocol. So I think, and I think the family history was a lot more helpful when every family had 7 or 8 kids, and now most people do not have that many children anymore. So, I mean, any comments on this? Dr. Dai, I know you guys are very much so a little bit more focused on family history.
I mean, we focus on family history, but we do, again, a lot of screening is also personalized. So there's also sometimes patients have symptoms that make us suspicious. And then there's also, having new onset diabetes. That's also another factor that typically prompts us to lean towards getting some sort of imaging. It may not be an endoscopic ultrasound. Sometimes we say we're fine with starting off with an MRI. So.
Yeah, let's delve into this a little bit. So let's say you have a high-risk mutation. What are symptoms that make you very suspicious?
The difficult part about pancreatic cancer is that, and one of the reasons that it's often diagnosed in later stages is because the symptoms are not very specific. So if a tumor is in the head of the pancreas, it often compresses the bile duct and leads a patient to get jaundiced. So we say that a patient who does not have abdominal pain who's jaundiced, that's usually pretty worrisome for some sort of tumor in that region. That could be a head of the pancreas tumor. It could also be a cancer of the common bile or of the bile duct, a cholangiocarcinoma. But usually in that situation, you don't, ideally you don't want to wait for someone to get jaundice to figure out that they have a cancer. So then the other region so then I sort of divide into other areas where people grow pancreatic cancers would be in the body and the tail. And the problem here is that it can cause some abdominal pain, but it's often very non-specific. So usually I tend to err on the side of caution with high-risk individuals. I just say that if you have any abdominal pain, let me know. And my sort of threshold to get either an imaging or perform an endoscopic ultrasound is just much lower. So.
Yeah, I think I would agree with that. Even in the BRCA or the hereditary cancer clinic, if someone has new symptoms, definitely something that lasts more than a week or 2 and is persistent, we probably very quick of referring patients for an evaluation. And I would say as patients and the audience here, if you have persistent symptoms, you should probably insist that your doctor would be more proactive, particularly if you're high risk, because often pancreatic cancer has not a lot of symptoms actually.
Yeah, Dr. Munster, you're absolutely right. I think just the symptoms are very non-specific, and I think especially, and, you know, from I'm an imager too, so kind of talking from an imaging standpoint that we are unfortunately seeing more cancers in younger patients. And I think it is a mistake to assume, you know, even for some doctors to assume that you're too young to be getting cancer. So it is important to be your own advocate. And like Dr. Munster said, to insist that something is not feeling right, that, you know, that needs to be worked up, and not just to ignore that.
And then I would also say, like, I mean, we set the age of starting to screen at 50, which is probably pretty arbitrary. I think as a medical community, we like round numbers, even though the colonoscopy screening have been set down to 45 from 50, which is not a round number. But I think if you have a first-degree family member who is diagnosed with pancreatic cancer at 45, we probably would start screening at under 40. We typically say 10 years younger, despite the fact that that's maybe a high burden. And then I think if you come to our clinic, there's certain mutations where we probably start sooner than 50. And so I think really the goal of the hereditary cancer clinic is that patients with or individuals with mutations get really personalized recommendation based on their circumstances, their family history, and their mutations. I think there was a question for you, Dr. Dai. Did you answer that, or you want to just take that question? You stated that diverse effects occur about.
Oh, yes, I'm typing this out right now, but I can answer. So 1 out of 2,000 is really just a broad ratio that we quote for all GI procedures, not just endoscopic ultrasound. And this is something, and this is not a UCSF specific rate. This is just sort of applied broadly to like anyone doing procedures as a gastroenterologist. When perforations do occur, if you are by the book, the gold standard of treating a perforation of the bowel is for the patient to have surgery. However, endoscopic devices and techniques have evolved immensely, and oftentimes, if we are scoping a patient and we see that we've created a perforation, we're able to close it right then and there. Most likely, the patient still needs to get admitted just for monitoring, but we are able to avoid surgery, avoid any other any other invasive procedures.
Great, thank you. So our question is, will we be approached about participating in this pancreatic cancer screening study? Do we need to take initiative? I would say both. We try to reach out to you, but we often don't have your specific details. So please reach out. Dr. Taniwaki is going to have the number for the study linked to the link for the webinar. Another couple questions. Anything I can do to reduce my increased risk of hereditary pancreatic cancer? Anyone?
Well, that's a tough one. I think, I mean, certainly take good care of yourself, you know, just general health maintenance, and I think is important. And, you know, do think about getting really screening. I think it's at this time, it's probably the best thing to do.
I think there's a couple of things that we know that are risk factors for pancreatic cancer. Of course, one of them is alcohol. Obesity may or may not be a risk factor. I think the data is still somewhat immature, but possibly. So alcohol in moderation is clearly a very good recommendation. Probably a modicum of exercise would also be good. But that's sort of like my own hobby horse. And then I think the most important part of hereditary cancer is really have your relative tested for the genetic mutation, because it's like what we see so many times that we know that an individual has a mutation, but their whole family has not been tested. And sometimes it's hard. A lot of people don't want to be tested. But I think I know from personal experience with my family, you may have to ask more than once for folks to get tested. If we have lots of resources to get you tested, so keep on your relatives to get tested. Are there any upcoming serum biomarkers that look promising? Jane, Sun?
I take it that that's in terms of screening for early cancer. Well, it's not my area, but I do collaborate with physicians who are very active in this area. There are these blood tests that are being studied in terms of picking up early cancers. Again, it's not my area, so I don't know the specifics other than that there's a lot of work ongoing, and there are some promising blood tests looking at tumor DNA circulating in the blood with the hope that it can pick up early cancers earlier than imaging.
Yes, I think everything I hear about in this area, I think the most promising, or the one that seems to have the most attention, is the circulating tumor DNA. But that appears to still be in its relatively early stages. Right now, people have talked about the one blood test that does exist is a serum CA19-9, which is often used for other purposes. It's actually often used by oncologists to track disease activity in people who already have cancers. So this blood test has been around for a very long time, but that hasn't really been shown to be a very helpful screening tool. Interestingly, if a lot of patients in Asia get physical exams, and this gets randomly checked, and so oftentimes we get sent patients who were traveling elsewhere, or maybe they live in both continents, who come back with a CA19-9 that's high, but it's in my experience, it has never actually meant anything of any significance.
So there's an approved test that's consumer directed. It's the Grail or Gallery test where pancreatic cancer is on the profile. It has a fair number of false positive, meaning you pick up circulating DNA that's not related to cancer, and it misses a few, but these tests are incoming. Another reason why I'd like to have a shout out for you to come to the clinic and give us blood and saliva, that we can start developing new tests. And a lot of these newer tests look a lot more promising. And I don't think these tests will replace imaging, but we may have a complementary test that can be done more often, because the next question would then be, pancreatic cancer is very aggressive. Is once a year screening sufficient?
Oh, sorry, I was muted. That's a really great question. I think there were a couple of questions related to frequency of screening. Right now, the practice is yearly screening, and it could be alternating between MRI and EUS. Now, I think one of the questions says, why don't we screen more often, every 6 months? And that's a great question. I think, especially with these screening guidelines, they're challenging, because what you want to balance is really the how many you're picking up versus how many patients you have to screen to pick up a single cancer. We certainly can screen very frequently. We can certainly do MRI very frequently, but at a population level, how many more are we able to pick up? And, there's costs associated to that, with that as well. So I don't know the answer. I think that there people looking at the appropriate screening interval, and currently it is yearly, alternating between, I think most places, most studies have looked at alternating between MRI versus EUS, but certainly that could also be variable as well.
So I think then the same question is, of course, like, so when do we start screening? Answering the question from the ANCAN Foundation is like, our recommendation now are 50, 10 years younger than the first degree relative. I think this will be evolving. I also feel like when do we stop is very, very dependent. What is your life expectancy? I think if we expect someone to live to 101, it's probably not reasonable to say they should stop at 70. But I think many of these things will be evolving and maybe very personalized. I think hopefully the blood test and DNA test will take some of the burden of the intense imaging-based or procedure-based screening and not make it more frequent. Dr. Dai, I adore you, but I don't want to have this EUS every 6 months. Like, as I can attest, he's really, really skilled, but it's not a trivial test. So I think a blood-based testing would also allow you to have it done locally. So I think a lot of research is happening in this area. A question is like, is BRCA mutation or ATM mutation, the associated pancreatic cancer, is more aggressive? We don't know about more aggressive, but we do know that they're more treatment sensitive. They really respond a little bit better to therapy, even a more of a reason to test for these mutations. So I think in breast cancer, the BRCA mutation and other mutation testing is very, very clearly driven by not just by family early detection and general prevention and early detection, but it's also for therapy. We do treat BRCA, ATM, PALB2 patients differently than we treat patients with no mutation. So I think this is relatively important to do that. Why is pancreatic cancer so deadly and hard to treat compared to other cancers that have seen breakthroughs such as lung cancer?
Well, that's a great question. I think part of it is because we are currently detecting it too late, that we're detecting it at a much later stage. And as I mentioned in my slides, that the survival is very, very dependent on the stage at diagnosis, which, obviously ties nicely to this topic of early detection. Especially in high-risk individuals, but really across general population, how do we detect cancer, pancreatic cancer early? So it's an ongoing area of ongoing active research for early detection. But the main reason it's so deadly is because we're not catching it early enough.
And then, Dr. Wang, that's probably a question that you may want to address, and now you have something to say about what about pre-nova or the other whole body MRIs? I just like to point out, like, Dr. Wang is a specialist in MRIs, and her specialty is the pancreas. She spends her life looking at the pancreas. I don't think you can find anyone better than her looking at your pancreas. So if someone looks at a whole body MRI, you're not going to get the same as what you get with Dr. Wang. But what is your take on pre-nova? Should people do whole body MRIs? And like, what do we do with this? And how good are they?
Yeah, well, that's a very good question. I think the whole body MRI is kind of all the rage. You hear a lot about that in the news. For patients at general risk for cancer, there is currently no evidence that whole body MRI actually will how should I say, a whole body MRI, there's no clinical evidence that a whole body MRI will pick up cancer and improve survival. However, whole body MRI may be, and that is not to say that it is not useful. It is just currently we don't have evidence to show that whole body MRI is useful for patients at average risk. For patients at high risk, I think it is a different story. Whole body MRI obviously is looking at the part of the it's looking at more than just the pancreas, and it may be helpful I would say that usually whole body MRIs are not targeted exam, so it doesn't have the high resolution imaging to look at the pancreas, and I don't know that there's data to show that it could replace a dedicated pancreatic protocol MRI with MRCP for the purpose of screening in high-risk patients. It does look at other parts of body and it may be able to pick up other unsuspected cancer, for example, small breast cancer in BRCA, patients with BRCA mutation. But I think currently it doesn't, it hasn't been shown that it could replace a dedicated abdominal MRI specifically to look at the pancreas. And again, for patients at average risk, there's no evidence to show that it could actually save life.
Dr. Dai, you want to add anything to the Pronuvo question?
Actually, I was just about to ask Dr. Wang, but I think she answered it. I was curious as to how great imaging of the pancreas you get from Pronovo compared to the dedicated imaging that we're doing. But you know, sort of a funny thing, but I just saw a patient a few weeks ago who ended up getting a Pronovo, and incidentally it picked up what was said to be likely a splenial, meaning like a part of the spleen that was right next to the pancreas. I had her get an MRI, MRI here. They saw the lesion. They said also it's possible to be a splenial, but they weren't as confident as the Pronovo. So I ended up doing a biopsy, and it came back as a solid pseudopapillary neoplasm, which is a very rare tumor that grows in the pancreas. There's no way anyone would have suspected that that's what this was, or and the patient didn't have any risk factors, but this was something that she ended up getting this surgically removed, because that is something that can, if left in place, turn into a cancer. So I usually discourage the Pronuvo MRI just exactly for the same points as Dr. Wang has made. But of course, one patient I saw, the most recent patient I saw who had one, it actually picked up something that was potentially life-saving for her.
So I think if you summarize this question, is like we don't have a good answer for Pronuvo on like what it really does, what its value is. I feel very strongly to say that if you're high risk for pancreas cancer, do a dedicated pancreas imaging or pancreas procedure for screening. Don't do Pronuvo. I think Pronuvo is not set out to be a pancreas cancer specific test. Is that fair to say? Would we all agree on that?
Yeah, absolutely. I mean, think about it. It has to cover many parts of the body. It cannot do as good of a job looking specifically at the pancreas. That's just reality.
Hey, what about pancreatitis? How do we screen for pancreatitis, Dr. Dai? I think if you have a pancreatitis gene, the screening test, well, what do you do for pancreatitis?
Well, most causes of pancreatitis are not due to a mutation, and the most common cause of pancreatitis in America is gallstones, actually. So if you have any stones that fall out from your gallbladder and into your bile duct and temporarily block your pancreatic duct, that is the most common reason people get pancreatitis. If you have that, that does not mean that you are at an increased risk of getting pancreatic cancer. However, there are these mutations for hereditary pancreatitis, that would be the SPINK1 mutation and the PRES1 mutation. So these are mutations where there's they're autosomal dominant. There's a very strong familial pattern. We often suspect this when we see young individuals who get repeat episodes of pancreatitis, and especially if they have a strong family history where either a parent or sibling also had pancreatitis or died from pancreatic cancer. These are the types of patients where we do perform genetic testing, and we do screen those patients annually.
There's a good question that I feel like we should actually answer. What if I have a family history of pancreatic, breast, colon cancer, and other cancer, and I don't have a genetic mutation? And that patient is worried, but doctors won't do any tests. What should that said individual do? And I can tell you from our clinic, if you don't have a mutation, we have a family clinic we go by family history. Like in breast cancer, we make very strong recommendation based on family history without genetic mutation. So I think same is true for pancreatic cancer. But what do you think, Dr. Dai? If I send you a patient who has a first-degree relative who had pancreatic cancer at 51 and has no mutation, would you do an EUS?
I don't usually recommend getting an endoscopic ultrasound for this. However, sometimes again, a lot of pancreatic cancer screening in my clinic tends to be a little more personalized, and if there's other compelling reasons to embark on a screening program, I don't want to withhold that from patients. But there just has to be a very great understanding that this is a big commitment. You're getting a test every year, and in terms of how we're screening it, right now we're doing this annually, but this is still, as we've mentioned, very much a work in progress, and we're still trying to fine tune what the most effective way is. I will say that for colon cancer, getting the gold standard for colon cancer screening is doing a colonoscopy. It is not an abdominal MRI is either, whether it's a Prenovo or an MRI abdomen, is not really great for picking up colon cancers. I think a few years ago, there was a lot of attention for a CT colonography, but even that hasn't necessarily replaced screening colonoscopies.
Thank you. That's helpful. Are there any promising studies on pancreatic cancer prevention?
That's a great question. I don't know the answer to that. I think it's yeah. I mean, certainly, as Dr. Munster mentioned, a lifestyle modification really important just for general health, but I'm not aware of specific pancreatic cancer prevention studies that I assume you're talking about, maybe medication related, that I'm not aware of, but certainly, lifestyle modification is for general health is good.
Our wonderful nurse practitioner who sees most of our patients, who's also sending out all the invitation, has reminded me that smoking is a risk for pancreatic cancer, and do not smoke. I think smoking is so rare in San Francisco, or maybe I don't go out enough. I don't think of smoking as much anymore, but it's clearly a risk factor. The BRCA Center, which is a hereditary cancer clinic in Philadelphia at Penn, they have a vaccine. There's a vaccine for BRCA mutation carriers. It's a bit unclear how they make the vaccine individualized. So I think if you look into that, if you want to look into that, that's via the Vassar Center. So there's a couple of vaccine studies in coming. I think the PARP inhibitors that are used for advanced pancreatic cancer are somewhat looked at in the earlier setting. In early stage breast cancer, it has been used, but in the prevention, giving its long-term side effects, but people are still a bit more hesitant. So I think a big part is on really early detection and early removal of pancreas. And I think what you said is like, it's just really hard to detect pancreatic cancer early. It's kind of like a bad spot in your body. It's like, it doesn't make easy symptoms. And then just being aware that don't neglect any symptoms you have. Okay. So another question that comes up a lot in the clinic, Dr. Wang, is people have breast cancer screening and pancreatic cancer screening. So 55-year-old still has not undergone mastectomy, wants to do breast MRI and pancreatic cancer MRI. Can they do this in the same setting? Is that doable?
Yeah, so that's a great question. I would say if we want to really have a good screening exam, probably not at the same time, because the techniques and the positioning for breast cancer versus pancreatic cancer is very different. And we, for both breast and pancreatic cancer, we like to give contrast, but we want to image the organ of interest during what we call dynamic imaging. And you can really, when we do dynamic imaging, we have to focus on one area. And so it cannot cover both breast and the pancreas. So if we want to really get high quality exam for both, it should probably be done at different times. Now, if you're very limited in terms of time, we can potentially do it in one setting. Do the breast and followed by the pancreas. It's going to be a long exam. It's not preferred, but it is doable if there are other limitations.
Thank you. And then the question is like, how often should I have the MRI, MRCP versus EUS, both in 1 year, one alternating each? I think we covered this. I think most of our patients are getting MRIs and EUS alternating once yearly. Do you have any, are there patients, Dr. Dai, where you do this more frequently? Is there any cases where you feel strongly that it should be more often?
No, I don't have anyone where I strongly recommend more frequently. But just, every so often I may have a patient who says, look, I've been having abdominal pain for the past week and this is new to me. So I say, okay, well, why don't we just move up your screening a few months early and let's take a look. But otherwise I typically I also agreed about getting an annual alternating test. Again, some patients are very claustrophobic and they just will not tolerate an MRI even if taking any even if given a anti-anxiety medication. So those patients, I'm doing annual endoscopic ultrasounds. I also have a handful of patients who are adamant about not getting an endoscopic study and they're getting annual MRIs, but those are very much in the minority.
Great. That's a good question for both of you. Is like, are there any communities that are more affected by pancreatic cancer? And most importantly, what sets UCSF apart in screening and treatment? Now you have to advertise for yourself, you two.
Well, we really do try to provide really state-of-art imaging for pancreatic cancer MRI or screening MRI. And we're always tweaking our sequences, the way we acquire these images, and to see how we can get the best images. So I think that does set us apart from the other places. And a high quality exam, especially for MRI, it is very, very much dependent on the quality. A low quality MRI, a lot of times it's worthless. So have good techniques is critical, especially in terms of screening.
And I can answer for Dr. Dai. He's the endoscopy is really patient-centered and is very, I mean, it's really easy to be taken care of really well. The anesthesiologists want to find out what you need, what is helpful. I think the procedures is very quick. I want to speak for others, but I had a 4:30 procedure and a 5:30 I was at dinner, so it's pretty good.
Wow, that's impressive.
I know, right? Like, so I mean, I'm not advertising for you too much, Dr. Dai, but you are really good.
Oh, well, thank you. And it's always nice to have procedures where you don't find any lesions, because those procedures, you can get a very thorough exam of the pancreas in, roughly about 30 minutes or so. But in instances where you do have to take biopsies, that procedure becomes longer. I will say that in terms of endoscopic ultrasound, if anyone is going to be getting them on a regular basis, just please have it done with or at a center where they are experienced. I'm not necessarily trying to advocate for myself or UCSF, but just any sort of center where there's high volume. Because what we often see is people who finish their training where they're doing 300 to 500 procedures in that one training year. When they go out, there's no magic number, but people generally say you should be doing about 150 of these to sort of keep your skills sharp. But that just isn't necessarily true when you're going to, practicing in certain communities. So we have seen, so I have seen instances where, as you can see, the endoscopic images, they're either black, white, gray, and someone sees something that they think is a mass, but they're not really sure, and they stick a needle in it, and then there's, sometimes, pancreatitis occurs from that. Or I've also seen other instances where someone took a look and didn't see anything, and then I repeat the exam a few months later, and I find a cancer that really should have been seen a few months before. So just when there are doctors out there there's a lot of doctors who do endoscopic ultrasound, but just be sure that you have someone who's experienced and really does a high volume every year.
And I would also say, like, like, procedures always carry a risk for something going wrong. It is really helpful when you're at the center where there's lots of other doctors around. If something has complications, it's very easy for you to be moved to like an observation area of an ICU area that is different than when you're in an outpatient center in a private office. I think that's something to consider. And when as Dr. Dai says, like, mostly it's quick, but if you do need biopsies always put patients at an increased risk for bleeding or something, and more observations and more people. So I think it is really helpful to have a whole team around. I think we almost through with did we miss any questions that looking at, did we miss anything that we didn't answer? We're going through all of this.
Well, I guess the last question where someone is asking how do I get started with pancreatic cancer screening at UCSF? Are we able to provide any resources for that individual or their primary care to refer out to?
Yeah, that's actually a good question. I think we are very fortunate. We have a summer intern who's going to help us with our website that will provide all the resources where we can actually get this also started. I mean, in the link, there's the number to our clinic. I think it's still, I think it's still not quite as easy to get to UCSF as it could be sometimes. Reach out to the BRCA clinic, and I think Dr. Taniwaki just put it in the chat, braca.ucsf.edu. And I am exceedingly confident that by the end of this summer, our website will be a lot more informative and a lot more updated. With this, I can't thank you two enough. It's been extremely helpful. The webinar will be on our website, so if you want to go back and see what Dr. Wang's chance, the slide shows what the chances that you're diagnosed with stage 1 if you have more screening, please do that. Reach out to us anytime, and thank you for this very, very interactive webinar. My two experts have done an amazing job, but it's really good to have those questions, and it helps us find out where we need to find answers and what is important to you. So thank you very much, Jane and Sun. Thank you for doing this. Letitia, thank you for the organization, as well as Beth and Danielle, and have a good night.
Thank you. Thank you, Dr. Munster, and thank you everyone for attending.